You mentioned it briefly. Can you contrast times in the past where you did have privileges, and other times did you serve in any capacity where you did not have privileges to serve or function somewhat in this primary care provider role?
So in the service, when you first begin in the Air Force, at least, it takes a while before you are sort of credentialed to begin to do to see patients through direct access. There's some coursework. This was actually back in 97. So the therapists were graduating with their masters, and there were a lot of programs that didn't have a lot of emphasis on actually pharmacology or on radiology or labs and so forth. And so you would graduate with maybe just a little bit of information, but not a lot of practical information. And so the military actually felt like they did a very good job in preparing, actually kind of filling some of those gaps with therapists that desired to work as a primary care provider. So there's some coursework that the therapist would do. It's an advanced course, and so all of those areas would be covered. The way to order x-rays, actually when you should order x-rays, just the parameters around that. Also the same exact thing with the medicines and so forth. And so the medicines that we were allowed to order were basically anti-inflammatories and some muscle relaxants, the sort of thing that that you would typically see if you had a referral. And the patient would come in and they would be on those medicines maybe. So, and then a basic lab workup, we would have training for that and the way to order those tests and just those sorts of things. And then we'd also there was a chance to practice. So you would come back to the base that you were stationed at. You would have 6 months where you're basically practicing those skill sets just to kind of solidify that information. There was a mentor that you would have as well. So it was actually very structured. You'd hit the end of that 6-month period and you'd be ready to begin to use those skill sets. So that's the way it was kind of worked in the service. Now, since therapists they're graduating at the doctoral level, a lot more emphasis has been put on that skill set, on the medicine piece, on the imaging piece, and also the labs, and also actually looking at some adding when you may want to actually restrict the things this person can do in their occupation. Those are all sort of new areas, for PTs to really focus in on, but they're all actually needed, I think, to work to function independently. So that's the goal there. So in the service, we could do those things. Since I've actually retired and been working in the private sector, the issues that we have to deal with are different to try to get us to that level. The majority of the states now obviously have some form of direct access, and some of the states are a little more liberal than others. There are some states like Washington, I think actually Oregon, that have allowed therapists to order imaging studies, and which is pretty exciting. That's a step in the right direction. In the United States, at least, my knowledge, there is not actually therapists that are ordering, medicines or labs or those sorts of things yet. In the UK, it's interesting that the company that I went to work for, it's HCA. It's a very large healthcare system. They also have some clinics over in the UK, and so I've had the opportunity to visit with their head of therapies for the UK, and the NIH and national are the NHS. They're national, the NHS, their National Health System Association, whatever it's called. Yeah. they allow physical therapists to practice fairly independently. So there are therapists that they're able to order medicines, they're able to do all the things that I mentioned, not only with musculoskeletal patients, but they also do it with pediatric patients. They do it with just the gamut, the full complement of patients that a physical therapist would normally see during their day. So that's actually very exciting. Some of that was actually driven by the same sort of issues that we saw in the service. They were using the providers, they're up to their educational level. They were allowing them to practice up to their educational level. So, and in the UK, there's a shortage, like there is also here in the United States, of primary care providers. And so physical therapists have helped to really fill that void, sort of like nurse practitioners did maybe 20 years ago. As they begin to see patients independently. I think that's kind of where we're at right now, just on the civilian side of things. So some of the issues that I had in the service when I actually first started with educating other providers as to the capabilities of a physical therapist, they're the same sort of conversations that I'm having now with ED providers, family practice providers, even with administration within the hospital. They're not fully actually educated on a couple of things. One, the capabilities that we have, but two, that therapists and occupational therapists, they're now actually graduating at the doctorate level. Here recently, a couple of conversations that I had, that was all actually new information to the administrators within the hospital and also within our division. And so I actually think there's some education that we need to continue to do as physical therapists. I think the APTA, just in my opinion, could be just a little more, pushy in a good way to educate the ways that we can be utilized, and really begin to look at actually some of these areas a little more of a push.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.